Today we are going to start a very important topic, that is nucleotide metabolism. Nucleotide metabolism is a very important as per your examination, as per your syllabus. And the clinical manifestations related with this is also important. Okay? So we studied all these metabolism in different cascade way. You already know the meaning of nucleotides, that is purine and pyrimidine. And basically here we talk about adenine, uracil, thymine, cytosine. Okay? So we discuss these metabolic sections. Chemistry is already over. The chemistry of this part of this topic is already over, and we discuss about the nucleotides. You already know that nucleotide means there is DNA and RNA. And how this comes in the body? It is by exogenous pathway. It is by exogenous pathway. Where DNA RNA is present? Which type of food? In meat, cereal, red meat, and different types of such food. We take exogenous dietary sources, then it go further metabolism. Okay. And we divide this metabolism in different ways. First, we understand the basic concept of this nucleotide metabolism. Okay. So, this is the structure of nucleotide. Basically, it contains cyclic ring. It contains cyclic ring, the help of carbon molecule and nitrogen molecules. Okay. Okay. And is 1, 2, 9. So all the concept of this metabolism is formation of this structure. Formation of this structure. Student, try to understand the basic concept. Basic concept means what we are going to study. We are going to study the formation of this structure. Okay. So now first we studied the sources of different carbon molecule and nitrogen molecules. How can we get these sources? Such like that, I will take the example for the formation of peptide bond. What are the sources of nitrogen? That is amino acid. That is amino acid. Same as in this case, for formation of this structure, we need 4 or N. The source of this is four or N molecule, nitrogen molecules. There is the sources are glycine amino acid. Okay. For N and M9, there is source is glutamine. Glutamine. Okay. For the sources for 2 and 8, carbon molecule and 8 carbon molecules. THF. THF, you know, tetrahydrofolate. Tetrahydrofolate. Molecule 2 and 8 of these carbon molecules. What is that? Sources of carbon. Tetrahydrofolate. And for molecule 1, there is carbon dioxide molecules. So in this metabolic section, we studied the formation of this structure first, that is synthesis. Why I am going to give the sources of these different carbon molecules and different nitrogen molecules, that ultimately means in this metabolic, in this cascade pathway of this metabolism, this amino acid can participate. These amino acid can participate. We understand by different ways. Okay? And here is studied the metabolic cascade pathway. What I tell you that before going to start, we learn from this. We take dietary nucleic acid, that is mainly DNA and RNA, in the dietary sources. Okay, and this is further on going to the metabolic pathways and the formation of different deoxyribose and ribose sugar. So ultimately, for the formation of this nucleotide, what is the basis? That is ribose sugar. What is important? That is firstly ribose sugar. So there are two pathways for purine nucleotides. For purine nucleotide, we understand why. Firstly, we complete purine nucleotide today. Then in the next class, we understand pyrimidine nucleotide. Okay. So purine nucleotide, they are for AMP and for GMP. And there are two pathways. The first one is de novo pathways and second one is salvage pathway. De novo pathway is basically, why it is de novo pathway? Because we take this nucleotide as an exogenous source. That means it is non-essential. It is non-essential. That's I already tell you. That is a precursor for de novo synthesis of purine. Precursor. These all are what? These are precursors. Glycine are the precursors. Tetrahydrofolate are the precursor. Aspartate are the precursor. And carbon dioxide are the precursor for different carbon molecules in their structure. Okay? You easily understand with this diagram. Okay. For the formation of purine ring, there is requirement of nitrogen and carbon molecules. It is obtained by different amino acid like glycine, aspartate, glutamine, and other carbon molecules by tetrahydrofolate. What is the function of tetrahydrofolate? What is the function of tetrahydrofolate? It is helpful for transfer of one carbon moiety, one carbon metabolism, one carbon transpiration. Okay? So these are all are the sources. Now we understand the basic reactions of all this. I will make this cascade pathway on the board and you will make this on your copy. Why I am making? If you are writing this cascade pathway in a serious way, at least you have to understand something. If I will show you in the slide, then it is the easiest way to understand, but it is not like that. Okay? Now we complete it one by one. Ribose 5-phosphate. In the formation of this molecule, basically IMP, inosine monophosphate. For the purine synthesis, there are 11 steps. How many steps? 11 steps. So, PIP. It requires ATP. Write down all the steps. This is okay. Five phosphoribosylamine. 5 phosphoribosylamine. Help of enzyme PRPP glutamyl. Okay. Here we require glutamine. What I tell you? I will tell you that all these sources are being act as a precursor for this synthesis of different molecules. Why? One we easily understand first step. This is a second formation of ribosyl phosphate. That is glycinamide, ribosyl 5 phosphate. Glycinamide ribosyl 5 phosphate. Here, which precursor is required for formation of glycinamide ribosyl 5 phosphate? Which precursor is required? Which amino acid is required? That is glycine. Very good. Glycine. Now, in the fourth step, there is the formation of formyl glycinamide. Formyl glycinamide. This is fourth step. This is third step, and this is fourth step. Glycinamide, formyl group is here, and what is the function of tetrahydrofolate? It can transfer formino group. So there is main coenzyme what is required, that is THF. Okay. Methylene THF. I am not right full form here. You understand? M for methylene and THF for tetrahydrofolate. Understand? Tetrahydrofolate. And what is required here? Enzyme is transferase. Which enzyme is required? Transferase. Okay. Now from step 5th, after this step, This is step 5. This is the basic fifth step for my glycinamide is formed. And after this, glycinamide, there is cyclization. Formation of cycle is occur. For the formation of this amino aminoidazole ribose 5-phosphate. Why it is required here aminoidazole? Because idazole basically there is a formation of ring. Okay, for the cyclization of process, required this. It is required. Step. CO2 molecules. CO2 molecules with the help of enzyme carboxylase. So all these CO2, glutamine, glycine, aspartate, what is that? These all are the sources for the formation of this structure which I show you firstly. Understand? So this is amino imidazole, ribose 5-phosphate. Okay, this is your seventh step. Now, eighth step. Amino imidazole succinyl carboxylase 5-phosphate. In the step 8th, with the help of which aspartate, and here the ATP is required. ATP is required. All students, fifth line, all of you stand up, all four, all of you stand up. Fifth line you don't know? 1, 2, 3, 4, 5. What are you talking? Why are you laughing here? Why are you laughing here? Amino imidazole succinyl carboxylase 5-phosphate. Okay. How many steps are left here? 3 steps, 9, 10 and 11. So after then this okay. formation of hormone. So what is happening here? There is transferase enzyme is occur. Transferase and why it is per here, and after the bile group is transfer here, and after the transfer for menaamine lastly what is happening here? There is release of H2O molecule from this directly inosine monophosphate IMP. Now you can make different mnemonics to understand all this metabolic pathway. Different mnemonics to understand different metabolic pathways. Different mnemonics you will understand. Either it directly by, if I will tell you it is ribosol phosphate, PRPP, phosphoribosol phosphate, फिर PR phosphoribosol, then GRP, FGRP, ARP, ACRP, these all are what? These all are the substrate. If I will tell you it is substrate, what is that? These are the substrate. Ribosol 5-phosphate, phosphoribosol 5-phosphate, 5-phosphoribosol amine. So all these you understand, these metabolic pathways. Okay. You will see from this slide also that is ribosol 5-phosphate, phosphorpyrosol, PRPP. Okay. So before going to read from this slide, I will tell you something that is helpful to you about this cycle. All of you write it. सबने लिख लिया ये? देखिए 3 and step synthetase. Understand that step 1, 3, 5, 6, 8 all are required ATP. 5, 3, 1, 3, 5, 6, 8 all are required ATP and the enzyme for this step is synthetase. याद रहा दिमाग में? All of you understand? 1, 3, 5, 6, 8. तो इस एंजाइम आप बेसिकली याद करते हैं. See what is common to and very good. That is glutamine, glutamine, glutamine. Okay, and now you understand this cycle with this way. Step 3 required what? Glycine. You will see 4 step and 10 step. That is transferase enzyme. What is common in between? That is tetrahydrofolate. Hydrofolate. Tetrahydrofolate. Okay, and your and 8 step aspartate is required. Aspartate. So by this method you easily understand these metabolic pathways. By this method you easily understand all this method. Okay. Regulatory step of this cycle is mainly one, that is main second step is regulatory step. Your second step is main regulatory. Main regulatory step is second. Okay, this is called de novo synthesis of purine metabolism. De novo synthesis of purine metabolism. There are two ways. There are two ways for this metabolic synthesis. First one is de novo synthesis and second one is salvage pathway. Salvage pathway. Salvage pathway is important for those important tissues and organs where this de novo synthesis is not happen. In the case of RBCs. Okay. So these are first de novo synthesis of amino acid. Now we understand with this cycle some important about this. FGR aminotransferase, FGR cyclase, AI synthetase, all these are we complete here. And they are main regulatory step in this cycle is mainly regulated in this way. The first one is PRP synthetase, which is mainly regulated by ADP and GDP, guanine diphosphate and GDP, and glutamine PRPP aminotransferase by feedback regulation. It is mainly regulated by feedback regulation. After then, next step is salvage pathway. Salvage pathway. Okay. So what it is about salvage pathway? Where this de novo synthesis is not happen, then there is salvage pathway for the purine metabolism. This involves the conversion of free purines to nucleotide is called salvage pathway. It consists of single reaction. Free purine bases adenine, guanine, hypoxanthine are formed in the cells during the metabolic degradation of nucleic acid and nucleotides, which are solved and used over again to remark purine nucleotides. So for the synthesis of purine, there are two methods. The first one is de novo method, and second one is salvage pathway. Salvage pathway comes in your exam also. It is comes in your exam. From the salvage pathway, there are different disorders we understand. Salvage pathway reaction is phosphoribosylation of adenine, hypoxanthine and guanine. Adenine, hypoxanthine and guanine. जस्ट अ मिनट, 1 मिनट टाइम दीजिए. There are mainly three reactions, very simple, nothing to understand. ज़्यादा नहीं इसमें कुछ है. Adenine is converted into AMP by adenine phosphorylase transferase enzyme with the help of PRPP synthetase enzyme. Okay, with the help of PRPP synthetase enzyme, this is first reaction. And in the second reaction, hypoxanthine is converted into ionosone monophosphate. Here it is formed, IMP is formed. IMP is formed by two ways. The first one is de novo synthesis. It is already right in your board. And second one is salvage pathway. Salvage pathway mainly consists three types of metabolic degradation reactions in which adenine, hypoxanthine and guanine is converted into different monophosphates. Adenine is converted into AMP, hypoxanthine is converted into IMP, and there is hypoxanthine guanine phosphorylase transferase, and guanine is converted into GMP. If this hypoxanthine enzyme is deficient, which diseases occur? That is gout is occur. अगर हाइपोजेंथिन एंजाइम आपका नहीं होता तो वहां पे कौन सा एंजाइम होगा? गाउट. यूरिक एसिड इंक्रीज करेगा कहीं ना कहीं, एंड दे अल्टीमेटली देयर इज अ डिपोजिशन ऑफ यूरिक एसिड इन सॉफ्ट टिश्यूज एंड फॉर्म्स अ डिसीज कॉल्ड गाउटी आर्थराइटिस. ओके, so these all are what? These all are the pathways you understand. I think you understand well. The first one is purine synthesis by de novo method. These 11 steps are considered. Second one is salvage pathway, in which three important reactions are there. Three important reactions are there. So synthesis is over, and in this metabolic pathway there are three regulated steps. PRP glutamate synthetase is regulation. It is regulated by feedback mechanism. Okay. Now catabolism. After the synthesis, which step is required? Catabolism. What is the meaning of catabolism? Huh? Breakdown, utilization. Utilization of this product in our body. What is the utilization of inosine monophosphate, adenine monophosphate? Okay, you will see there is a formation of uric acid lastly. Okay, so now is converted into hypoxanthine. 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 And xanthine is converted lastly into uric acid. Uric acid. With the help of enzyme, is xanthine oxidase. And from this hypoxanthine, it forms hydrogen peroxide, which is hydrogen peroxide reactive oxygen species, because it can the H2O, H2O2. Okay. Nucleotide, phosphorylase, is Okay. So ultimately, students, I summarize this and you easily understand the basic concept here. What we are understand today, we are understand today the purine metabolism. In the purine metabolism, the first step is synthesis. Synthesis mainly occur by two ways. The first one is de novo synthesis. In the de novo synthesis, the substrate is ribulose 5-phosphate. Which is substrate? Ribulose 5-phosphate. This ribulose 5-phosphate is comes from what? Comes from which molecules? By exogenous sources. You will take in the diet some nucleotides, DNA and RNAs. Okay. From this ribosole 5-phosphate, there after the 11 step formation, there is a formation of IMP. And there are three main steps, IMP, GMP and AMP is formed. Okay. IMP, GMP and some organ which are not follow up, some organ which are not, some tissues which are not follow de novo synthesis, where the salvage pathway are occur. The salvage pathway is what? It is an alternate sources for the formation of these nucleotides formation. By three specific reactions, we already understand. Okay? After then the synthesis of these, the next step is catabolism, and all this nucleotide, all these purines are catabolized and form here mainly uric acid. Okay. So uric acid is a metabolic waste product. Level of uric acid is normally 5 to 7 mg per dl. 5 to 7 mg per dl. If there is uricemia, hyperuricemia, and the disease caused by this high level of uric acid increase is known as gout. Gout. In the next class, we all understand about the gout and also the purine metabolism. Sorry, pyrimidine metabolism. Okay. So gout are two types. It is primary gout and secondary gout. Primary and secondary. So what is happening in the basically what is happening in the gout? There is deposition of this uric acid in metatarsals. These metatarsals in your feet toe, जो अंगूठा होता है ना उसके आसपास सब डिपोजिशन हो जाता है. There is swelling, inflammation occur. A painful condition occur. And for the treatment of this gout, what we give? We give allopurinol. Have you listened these drugs in your enzymology? Allopurinol, it is give feedback regulation and feedback inhibition and competitive inhibitions to which enzyme? Xanthine oxidase. Which enzyme? Xanthine oxidase. Okay? In clinical enzymology, you understand this. The allopurinol is competitive inhibitor of level of uric acid. That's why we tell some person whose level are high, we suggest them that not to eat a red meat. Red meat मत खाइए, कैफीन मत लीजिए, अल्कोहल मत पीजिए, बियर मत पीजिए. ये सब हम सजेस्ट करते हैं जिनको यूरिक एसिड हाई रहता है. ठीक है. अगर फिर भी उसको कंट्रोल नहीं होता तो देन वी प्रोवाइड अ ड्रग कॉल्ड एलिप्रोनॉल विच इनहिबिट xanthine ऑक्सीडेज. तो वहां पे xanthine ऑक्सीडेज को इनहिबिट कर देगा तो यहाँ पे यूरिक एसिड फॉर्म नहीं होगा. बट इट इज अ टेम्परेरी ट्रीटमेंट. इट इज अ टेम्परेरी ट्रीटमेंट. ओके. सो समझ में आया कि नहीं आज? You have to understand what about the nucleotide metabolism that we understand from this slide also. We completed here for the sources of this cycle, different carbon and nitrogen cycle. We have different amino acid like glycine, aspartate, glutamine, CO2 tetrahydrofolate. And there are 11-step process for the formation of IMP from substrate ribosol 5-phosphate. Which substrate? Ribosol 5-phosphate. And in the 11th step, you can also classify it. These are the salvage pathway. Okay. Now significance of salvage pathway. You understand about significance of salvage pathway. Some topic we cover from slide also. HGPRTase enzyme is hypoxanthine and guanine back to DNA synthesis. Failure of these enzymes increase uric acid, a purine breakdown product. The de novo synthesis is stimulated due to excessive of PRPP. Okay. So what is the significance? First significance, it is the alternate sources. It is the alternate sources of for some tissues where de novo synthesis not occur. Okay. And salvage pathway provide purine nucleotide for tissues incapable for their biosynthesis by de novo pathway, which I already tell you. By de novo pathway. Okay. Because human brain has low level of PRPP amidotransferase, the first enzyme. Due to this, human brain cells required which pathway for nucleotide metabolism? Salvage pathway. Okay. Erythrocytes and leukocytes cannot synthesize 5-phosphoribosylامine, therefore exogenous purines to form nucleotides. So all these are the cells which are not capable to perform de novo synthesis due to their deficient enzyme activity. Okay, due to deficient enzyme activity, these are not performing. Catabolism, we already complete catabolism. There are some disease, severe combined immunodeficiency, that is SCID disease. Okay, hypoxanthine is formed, AMP, adenosine, inosine, hypoxanthine, GMP, guanosine, guanine, which ultimately form xanthine, uric acid, which is excreted in the urine. And by the enzyme activity of xanthine oxidase, which is formed, hydrogen peroxide is formed. It is reactive oxygen species. And disorder we complete in the next class. For tomorrow, it is more than enough that you have to complete synthesis. De novo synthesis of nucleotide metabolism, purine metabolism, de novo synthesis, salvage pathway, after then regulation, after then catabolism. Okay, all of you three going to your room and studied well. If you have any queries regarding this topic, you will ask to me. Okay, thank you.
Morning, everybody. Today's discussion is vessels and nerves of the pelvis. Now, the pelvis, you know the situation where it is located, and the great vessels, they are ultimately they are going downwards and from the heart to the brain. But it's a big topic. I don't know how much I can cover up in this 1 hour, but I'll just go and show you some wonderful pictures, and you think it in this component. Okay, every organ is to be supplied. It has a vascular supply and it has a nerve supply. And nerves and the muscles, they come from some plexuses. And what are those plexuses? And what are the functions of this nerve supply of the pelvis? Especially the vascular supply and in these days of, in females I would say, of different pathological conditions of the uterus, ovaries, fallopian tubes, and the laparoscopic approach to combat the pathology. You are using as a diagnostic tool, See, if a lady comes with some infertility, so you don't just put a laparoscope, but you do an ultrasound, you do an HSG, you do some hormonal tests, and then you might need say HSG gives some information, histosalpingography. By 10th, 11th day of menstruation, a dye is pushed through the cervical canal in the uterus, and to see the journey of the dye in the fallopian tube, and if it is a spillage in the pelvis. Now, the common iliac artery opposite lumbosacral articular disc and is in front of the sacroiliac joint consists trunk, anterior and posterior division. In the course, the arterial trunk, the passes superiorly downwards in front of the sacroiliac joint. On reaching upper margin of the greater sciatic foramen, it presents anterior and posterior division. The anterior division extends as a continuation of the trunk up to the ischial spine. Posterior division passes downwards and backwards in region of the greater sciatic foramen. Now, the greater sciatic foramen and the course, now it has an intention. It will supply the muscles. Now, common iliac artery and its branches. In male, you can see the common iliac artery, internal iliac, external iliac, and it forms deep circumflex, and the inferior epigastric artery, the obliterated umbilical artery, the superior vesical artery, the urinary bladder is here, this is the symphysis pubis, and this is the prostate. And you can see now. What I am trying to say is that the major component, then it distributes all the organs in the pelvis. Now, this is the ventral primary rami of sacral 1, sacral 2, sacral 3, 4. These are the nerves. And iliolumbar artery, lumbosacral trunk, this is the lumbosacral trunk, lateral sacral artery, and this is the superior gluteal artery, the inferior gluteal artery, inferior vesical artery, and internal pudendal artery. When you read the perineum, there's a pudendal canal. Now, the contents of the pudendal canal can be a short note. You have to mention the pudendal artery. Even if a very well-preserved dissected body, you can dissect out and see the pudendal artery. Now, relations in front, pelvic part of ureter in female forms posterior boundary of the ovarian fossa and related to ovary and fimbriated end of the uterine tube. Behind from backwards, internal iliac artery, lumbosacral artery, sacroiliac joint. Now, laterally from above downwards, the medial border of psoas major, external iliac vein, and obturator nerve. Medially covered by peritoneum, crossed by terminal part of the ileum on right side and crossed by sigmoid colon and vesical colon on the left side. Now these relations, even when you are in osteology, you are given a pelvis. So when you describe the pelvis, you will ask what is the relation in the sacroiliac joint, what is the first in the lumbosacral joint. So these things come into. Here is another picture. The superior gluteal artery, see, this is the inferior gluteal artery, and this is the external iliac. These yellow are the lumbosacral trunk. This is the internal iliac, and here the obturator nerve, and this is the obturator artery. They accompany each other, and this is the medial umbilical vein, this dorsal artery of nerve of penis, and deep artery of penis, dorsal artery and nerve of the penis, and the artery and nerve to the bulb of the penis. Now posterior scrotal artery and nerves, external iliac has a branch of common iliac, and this is the internal iliac, which is superior gluteal, inferior gluteal, umbilical artery, obturator nerve, and internal parietal artery. Now, see the dorsal artery and nerve of the penis. Now, any condition like you want to do circumcision for phimosis or paraphimosis, a tight prepuce retracted, it forms edema and it doesn't, again, you cannot drag the skin, foreskin of the penis. Then you just, even in malignant condition of the penis, now this is the malignant condition, the carcinoma, squamous cell carcinoma of the glans penis, or there might be a stricture urethra. It, it can be the anterior stricture. So, the first thing, an aged person with retention urine comes, then there might be a growth in the glans penis, or most common cause is balanoposthitis. That is the infection of the foreskin and the glans, and it forms a small penile opening, and also the prepuce cannot be retracted. In that condition, you just infiltrate, catch hold of the penis, put some xylocaine jelly in the foreskin and this thing, and then try to negotiate a thin, small catheter, like 12 FR, 14 FR, 15 FR, 16 FR. These are the gauge of the diameter of the Foley's catheter. And if there is some stricture in the urethral anterior opening, Then you take a small dilator and just you try to open and see it, the person will urinate. If there is no posterior stricture and the anterior portion of the glands, if you can this is the growth tourniquet, tie it down tight, and then you do partial amputation of the penis. If there is some injury, machine injury or road traffic accident, you don't have to, you try to preserve and say if the penis is half cut, then you infiltrate and you have to repair. Pass a catheter and see, and then repair the urethra with stitches, and also at least if you are not having that thing, if the catheter passes or slightly injured, the catheter will support এটা urethra একটু ইনজুরি catheter এটা রেখে দিলে it gives a support that will heal up. তো এখানে যে মূল জায়গাটা যেটা আছে সেটা আমি বলতে চাইছি, what I want to speak out that these small procedures, even a boy of 6 years, 5 years, 4 years can be circumcised under local anesthesia. Now classification, the parietal branches, obturator, superior and inferior gluteal, internal pudendal, iliolumbar, lateral sacral arteries, visceral branches, umbilical, superior and inferior vesicle, and middle rectal, uterine and vaginal artery. So you just know the organs which is accommodated in the pelvis. Then that main major supply from there, superior rectal, inferior rectal, you build up the story. Okay. Now, this is the aorta. Now, urethra, common iliac, external iliac, and superior gluteal artery, inferior gluteal artery. This is the uterus. This is the obturator artery, umbilical artery, inferior bladder, pudendal artery here, and middle rectal artery. This is the vaginal artery. Branches, posterior division. Now, iliolumbar artery, superior gluteal artery, lateral sacral artery. So it becomes easy if you just correlate with the pelvis. Now, iliolumbar artery, the course passes upwards and laterally in front of the ala of the sacrum, between lumbosacral trunk and obturator nerve, and then divides into iliac and lumbar branches. Iliac branches passes beneath the psoas major and iliacus muscle, reaches iliac fossa and provides branches to the aforesaid muscles and nutrient branches. Lumbar branch ascends through the psoas major and associates with fourth lumbar artery and sends the final branch through the intervertebral foramen between fifth lumbar vertebra and sacrum. This is important. Here you see the iliolumbar artery, the obturator artery, and the lateral sacral artery. See the nerves to the sacral foramen, and inferior gluteal artery passes through the obturator foramen. Now this is superior gluteal artery here. Now parietal branches from posterior division, iliolumbar artery, lateral sacral arteries, 2 branches, and superior gluteal artery. from the anterior division, obturator artery and inferior gluteal artery. Superior gluteal artery, the largest branch of the internal iliac, passes backward between lumbosacral trunk and first sacral nerve, leaves pelvis through the greater sciatic structures which passes through the greater sciatic foramen in your Viva. They can ask you when they give you in histology the pelvis. Now, greater sciatic above piriformis and appears in gluteal region. Now, lateral sacral arteries usually consist of upper and lower branches. Upper branch enters through the first or second pelvic sacral foramina. Lower branch descends in front of the piriformis, sacral plexus of nerves along the lateral margin of pelvic sacral foramina. Both arteries provide spinal branches through the sacral foramina which supply contents of sacral canal and finally emerge through the dorsal sacral foramina. এগুলো তোমরা কোরিলেট করবে ডেড বডিতে। Now, obliterated umbilical artery, continuation of internal iliac artery, the intrauterine life, where it reaches to placenta through umbilical cord and conveys deoxygenated fetal blood to chorionic villi. With cessation of placental circulation after birth, distal part of the umbilical artery is obliterated to form the corresponding medial umbilical ligament, and proximal part remains patent as superior vesical artery. The fate of operated umbilical artery. This can be a short note. Now, superior vesical artery derives from the non-operated part of the umbilical artery and consists of 2 or 3 vessels which supply upper surface of the bladder. One vessel accompanies vas deferens, supplies it and reaches testes where it announcers the testicular artery. A few vascular twigs supply terminal part of urethra. Now, in retention of urine, the suprapubic cystostomy this sympathetic pubis. Now, right up. This is the rectal sheath. Okay. Now, what happened? You have to do a quick maneuver. Then you infiltrate from the umbilicus to the sympathetic pubis. You infiltrate with local xylocaine, and your catheterization has failed. So you need not worry, you can do it as a emergency procedure. Of course, now all health centers are furnished. So you just infiltrate and make an incision, then you slowly dissect out. The bladder is full, naturally you can see, and you can put 2 sutures. Like you lift up the some blood supply to দেখো and a pool of blood হবে না. It is just the superior vesical artery is ramifying on the bladder. Naturally, you make a small incision, put a small catheter, 16 FR, and then Foley's catheter below the balloon and just suture it. And then you suture the skin. So, এখানে the importance and the এগুলো করা যায় এবং করি আমরা। এই স্পাইনাল অ্যানেস্থেসিয়া হবে, হাত তুলে হাত ধুলাম, তা না, এগুলো হচ্ছে ইমার্জেন্সিস। বেশ, এবার কথা হচ্ছে now again a nice picture. Internal iliac, obturator, superior inferior vesical artery, middle rectal, internal pudendal, inferior gluteal. Now, inferior vesical artery arises separately or in a common with middle rectal artery and supplies base of the urinary bladder, terminal part of the ureter, and seminal vesicle, ampulla of vast deferens and prostate. Corresponds to the vaginal artery in female. Now, inferior vesical artery corresponds with the vaginal artery in female. Now, middle rectal artery passes downwards and medially through pelvis, rectal space, within lateral ligaments of the rectum, supplies lower part of the rectum, provides few twigs to bladder and seminal vesicles. Now, obturator artery passes through the and downwards along the lateral pelvic wall accompanied by obturator nerve above and corresponding vein below. Passes forwards and downwards along lateral pelvic wall accompanied by obturator nerve and corresponding vein below. Now, these structures leave pelvic cavity through obturator canal and thereafter divides into anterior posterior branches around margins of the obturator foramen. এগুলো কিন্তু মানে অস্ট্রোলজিতে pelvic bone or the pelvis they'll be asked. মানে you don't take it যে এগুলো দরকার নেই। মানে সব রকম ভাবে প্রিপেয়ার থাকতে হবে এবং সেটা তুমি বললে বাট ওয়ান থিং আই টেল ইউ that if you are saying very nicely, your viva, your presentation is good, then the examiner will try to give you honors. So ওটা হয়ে যাবে নেই আর ঘন্টা বেজে গেছে। Wait. Now a similar picture. Now, abnormal obturator artery, pubic branch of obturator artery and pubic branch of the inferior epigastric artery and anastomotic arch presents variable relation with the femoral ring. Now, in 20 to 30% cases, such anastomotic channels become prominent and forms an abnormal obturator artery, which replaces the original artery and might produce hazard in surgical approach of the strangulated femoral hernia. At least few thousand hernia operations I have performed and different types of hernias. But I have not encountered till date, I want to encounter a femoral hernia. It is more common in the Western world, especially in female. So I didn't have the opportunity to see a femoral hernia. But I have seen all the hernias, more or less. Now, the uterine artery initially accompanies lateral side of the pelvic part of the ureter. This is very important, very important, very important. On approaching supravaginal part of the cervix, it crosses above and in front of the ureter from lateral to medial side and then passes upwards through the lower attached margin of the broad ligament where artery runs tortuously upwards along lateral margin of the body of the uterus. Finally turns laterally below the uterine tubes, enters ovary through the mesovarian and anastomosis to the ovarian artery, supplies the urinary bladder, terminal part of the ureter, vagina, uterus, part of the uterine tube, ovary and other contents of the broad ligament. Now this is important because see the course. Now any operations of the uterus like abdominal hysterectomy or vaginal hysterectomy, you have to take care of the ureter and accordingly deal with it. Here's a beautiful picture. You can see the ligament of ovary, and this is the ovarian artery and vein, fallopian tubes. This is the ureter. See the close division, this part, this part, this part. And the uterine vein, the uterine artery, it is going up, it is going down, supplying the vagina and also the uterus. And position of cesarean section, hysterotomy on anterior surface of the uterus, internal pudendal vessels, and internal iliac artery. Now, vaginal artery corresponds with the vesical artery of male and passes downwards and medially to vagina, and where it divides into several small branches. The branches are not in the median line of midline, in front of and behind the vagina, and forms anterior and posterior zygous arteries of the vagina. Supplies vagina, bulb of the vestibule, urinary bladder, and rectum. Inferior gluteal artery, one of the terminal branches, passes downwards and backwards between the ventral rami of first and second sacral nerves, or between second and third sacral nerves. Finally leaves the pelvis through greater sciatic foramen below piriformis muscle and appears in the gluteal region. So the gluteal artery, if you ask muscles of the, what is the gluteal surface, gluteus maximus, gluteus medius, gluteus minimus. Now, what is the arterial supply, what is the nerve supply? So, now internal pudendal artery, I told you earlier, that the terminal branches and leaves pelvis through greater sciatic foramen and between piriformis and the coccygeus muscle. Crosses dorsal surface of ischial spine and where it is related medially with the pudendal nerve. Thereafter, artery enters perineum through lesser sciatic foramen, passes forwards and through the pudendal canal or Alcock's canal in lateral wall of the ischiorectal fossa, and appears in deep perineal pouch along with ischiopubic ramus, where it divides into terminal branches, the penis and clitoris. Now, the Alcock's canal might be a short note. Naturally, you have to definitely mention the pudendal artery, nerves and vessels, and the course of this, and the position of the canal, pudendal canal, Alcock's canal. Here's a beautiful picture from Grays. You can see the scrotum. You can see the bulbocavernosus, ischiocavernosus, and transversus perineal, tubal ischial, and fascia lata, and this is opened. This is opened, and you can see the gluteus maximus muscle and the posterior scrotal artery, the posterior scrotal veins and pudendal nerve, internal pudendal artery here. Now this is in lithotomy position. It's in lithotomy position. The what is lithotomy position? Now these are the thighs. Now similarly, this is lithotomy position, and internal pudendal artery branches in perineum. What are the branches of the internal pudendal artery? It's a small artery, but it has branches in the perineum are the inferior rectal artery, perineal branch, artery to the bulb of the penis or vestibule, urethral artery, deep artery of penis or clitoris, dorsal artery of penis or clitoris. Now, inferior rectal artery arises in the pudendal canal, traverses medially in arched manner across rectal fat, supplies structure of the perianal regions. Perineal branch arises in the anterior part of the pudendal canal and appears in superficial perineal pouch by piercing perineal membrane, where it divides into a transverse perineal artery and two posterior scrotal or labial arteries. Artery of the bulb of penis or vestibule in deep perineal pouch. This artery pierces the perineal membrane and supplies the erectile tissue of the bulb and corpus spongiosum of the penis in male or bulb of the vestibule and vagina in female. Urethral artery pierces perineal membrane and supplies urethra up to glans penis. Now, deep artery of the penis or clitoris pierces perineal membrane and enters glans penis or clitoris, supply erectile tissue of the corpus callosum. Now, dorsal artery of the penis and clitoris, after piercing the perineal membrane, the artery passes upwards, forwards the crus or clitoris and symphysis, then runs forward between two layers of the suspensory ligament of the penis or clitoris. Now, then it lies beneath the fascia penis or dorsum of the penis, where it is accompanied by dorsal nerve laterally and unpaired deep dorsal vein medially. Supplies prepuce and glans and provides numerous circumferential branches around facial sheath of corpus cavernosum and assumes the deep artery of the penis of clitoris. Nerves of the pelvis. Now the nerves of the pelvis include lumbosacral trunk, sacro and coccygeal plexus, sacral and coccygeal plexus, autonomic nerves, pelvic part of the sympathetic and parasympathetic system. Now, lumbosacral trunk L4, L5, it is thick cord-like nerve formed by the fibers of the ventral primary ramus of L4 and entire ventral primary ramus of L5 spinal nerves. Course, it descends over the ala of the sacrum. It crosses the pelvic rim in front of the sacroiliac joint. It joins the first sacral nerves to form the sacral plexus. Now, this is a thing that usually at a sacrum, histology তোমাকে ধরতে বললো, but a pelvic articulated pelvis ধরতে বললো. Then what are the relations of the nerves of the pelvis? And lumbosacral trunk, mainly the course. Now, sacral plexus is the plexus of nerve that lies in front of the piriformis on the posterior wall of the pelvis. Root value, এগুলো তোমাদের পরে পড়া হবে, L4, L5, S1, S2, S3 and S4. Formation, sacral plexus, lumbar plexus, this can be short note of 5 marks. And if there is some applied anatomy or something, it can be a question of 10 marks. Now, relation, the sacral plexus lies in front of the piriformis, deep to the pelvic fascia on the posterior pelvic wall. It lies posterior to the internal iliac vessel, the ureter and sigmoid colon. So, when you are dissecting the pelvis, then you can see the sigmoid colon, the vessels of the ureter and sigmoid colon, and then try to locate the sacral plexus. Now, this is the root values and its branches. जैसे superior gluteal L4, L5, S1, inferior gluteal L5, S1, S2, sciatic nerve, and common part of lumbar 4, 5, S1, S2, this part. And this is tibial part. It goes to the perforating cutaneous nerve and posterior cutaneous nerve of the thigh, pudendal nerve, nerve to the obturator interus and nerve to quadratus femoris. Now, these you have to learn your dissection of the lower. Now, sacral plexus, see, even this flow sheet, you can, any textbook will give you, so that will be the sacral flow chart into sacral plexus. If you're in a hurry, you're not, you can give a flow chart. It might be a question of 5 marks. Then you get this thing done. Descriptive না গেলে তুমি এটা দিয়ে দিলে নম্বরটা পেয়ে যাবে। এখন তোমাকে এইটা ঠিক মানে একটু প্র্যাকটিস করতে হবে যে হাউ উইল অ্যাপ্রোচ দি কোয়েশ্চেন আনসার্স, হাউ উইল অ্যাপ্রোচ, মানে তোমার এইটা এখন ফোকাস থাকবে। এখন আর ইন্টারনেটে নতুন ছবি নতুন বই এর দেখতে যেও না, তুমি যেটা আছে সেটা পড়ো। Now, some interesting facts. The lumbar four spinal nerves contribute to both lumbar and sacral plexus. The S4 spinal nerves contribute to both sacral and coccygeal plexus. And the superior gluteal vessels pass between the lumbosacral trunk and the ventral rami of the sacral one nerve. The inferior gluteal vessels pass between the ventral primary rami of S1 and S2 nerves. Equal branches of the sacral plexus. Now, the great MI, the median sacral artery. Now, sacral sympathetic trunk, ganglion impar, ventral primary rami of the sacral nerves. See, this is the sacral opening, sacral hiatus. Okay. Branches of the median sacral artery, branches from the ganglion impar to the coccygeal body. Presacral nerves are superior hypogastric plexus, inferior hypogastric plexus, and coccygeal body or glomus coccygeum. Actually, you just, what are the nerves coming down? What are the great vessels? Then aorta and vein. Then the pelvic pelvis is supplied by, তখন তুমি এইভাবে এগো। এখনই প্যানিক হয়ে যাও, কারণ what I briefed today, I would say briefed, is that you will be having lectures on perineum, you will having lectures on the plexuses, so you don't get panic. Thank you.
So today's topic is histology of ovary. Okay, it comes as a short note. Okay, 5 marks or 7 marks. So it is a part of female reproductive system. Female reproductive system, it divides into internal organs and external organs. Internal organs that are located in the pelvis, these are the ovaries, uterine tubes, uterus and vagina. All these three structures you have to learn the histology. Okay, ovary, uterine tube, uterus. And external genital organs that are located in the perineum, they are mons pubis, labia majora, labia minora, clitoris, vestibule, vaginal and urethral openings. Accessory sex glands are the mammary glands, Skinner's gland, also known as lesser vestibular glands, Bartholin's glands or greater vestibular glands, pregnancy-related structure like placenta and umbilical cord. All these are accessory sex organs. Okay. Now, menstrual cycle. Ovary and uterus shows cyclical changes under control of hormones, and these changes are called the menstrual cycle. What is menarche? Very frequently asked in Viva, and age is also asked. It is the initiation of menstrual cycle. It occurs between 9 to 14 years of age. Okay. Now, menopause. Menopause is also known as climacterium. It is the termination of menstrual cycles and it occurs by the age of 45 to 55 years. An average length of each menstrual cycle is about 28 to 30 days and it varies from female to female. Okay. Next, see, these are the internal organs or pelvic organs. This is uterus. See, the wall is how much thickened, and this inner lining is the endometrium. Endometrium is shed off during the menstruation. This is uterus. This is lower part of the uterus known as cervix. Okay. From the cornu of uterus, these are the two fallopian tubes. This is the terminal end, fimbriated end, and here lies the ovary. Okay, ovary is suspended by this ovarian ligament with the cornu of the uterus. From the ovary, the ovulation occurs, egg is coming out, and it is captured by this fimbriated end of fallopian tube. Then it passes through the ampulla. This is the site of fertilization. After that, the zygote passes through this and it is embedded within the endometrium and myometrium of the uterus here. Okay. Next. So internal organs are the ovaries, uterine tube, uterus and vagina. External organs are mons pubis, labia majora and minora, clitoris, vestibule, vaginal openings, and accessory sex glands are mammary glands, skinny glands, and Bartholin's gland. Okay, these glands are important because sometimes cyst formation occurs in these glands during infection. Don't talk. কি হচ্ছে ডিসকাস করলাম তো প্রিভিয়াস স্লাইডে greater vestibular gland or lesser vestibular gland. Next. Okay, so ovaries perform two major functions. Gametogenesis, this is production of ova or female gametes, and steroid hormone secretion, these two are secreted, estrogen and progesterone. Ovaries are almond shaped, pinkish white, paired gland. Okay, this is normal size. Dimension is about 3 cm in length, 1.5 cm in width, and 1 cm in thickness. Okay. Next. Each ovary consists of these structures. These structures you have to see in your histological picture. Okay. So outermost is the germinal epithelium. The surface of the ovary, it is covered by a single layer of cuboidal epithelium known as germinal epithelium, and this epithelium does not give rise to female gametes. It is a misnomer. Germinal means it should give rise to germ cells, that means oocytes, but it does not give rise to oocytes. Okay, that's why it is a misnomer. This is comes as I explain why germinal epithelium is a misnomer. Okay. So tunica albuginea, next covering on the inner aspect of this germinal epithelium. Germinal epithelium rests on the connective tissue layer called the tunica albuginea, and this tunica albuginea of testis is much thicker and dense than that of the ovary. In testis also there is a capsule, and beneath the capsule there will be tunica albuginea. Okay. Next. Next, after the tunica albuginea, you will get the cortex and medulla. Okay, cortex, it lies just beneath the tunica albuginea. It consists of various stages of ovarian follicles with oocytes or germ cells in a cellular connective tissue stroma. Stromal cells of the cortex surrounds the ovarian follicles and form the follicular cells. Corona radiata, cumulus euphorus, granulosa cells, theca interna, theca externa cells, and cortex also contains corpus luteum, corpus albicans, and atretic follicles. These changes occur after the ovulation. Okay. Next is medulla. It is located in the central portion of the ovary mainly. Why are you talking? If you don't want to do the class, just leave. I will give attendance. Don't disturb in class. Continuously talking some people. If you don't understand, ask me. Next. So these are the structures you have to see. First, the germinal epithelium. It is a misnomer, simple cuboidal epithelium, outermost covering. Then tunica albuginea, which is a connective tissue coat. Then cortex, it is containing the ovarian follicles in various stages, follicular cells, atretic follicles, corpus luteum, corpus albicans. Then there is medulla, it consists of the loose connective tissue, vessels and nerve fibers. Okay. So these are the presenting parts of ovary. Next, see here, this is a section through the ovary, histological picture. This outermost covering, you can see rounded, small rounded nuclei, okay, pink line, and within which the rounded nucleus are embedded. This is germinal epithelium, consists of cuboidal epithelium. Then beneath it, this connective tissue layer is the tunica albuginea, not much prominent. Okay, this is very thin layer, thin connective tissue layer. In the testis, it is thicker. After that, these small rounded structures you can see, these are the follicles. Okay, primordial follicles, some are primary follicles. Then if it is increasing in size and it will develop into secondary follicles, mature Graafian follicle. After ovulation, it will be turned into this corpus luteum. First corpus hemorrhagicum. This is hemorrhage within the corpus luteum. So first corpus hemorrhagicum, then it will start secreting progesterone and cells will be changed to luteal cells. Then it will be atretic and develop into corpus albicans. Okay. Here is also one corpus albicans. This is new one and this is old one. While old one is also getting reduced in size. Okay. And this part in middle part is the medulla. All these follicles, corpus luteum, corpus albicans, all are lying in the cortex of the ovary. And this in the middle part, here you see the section of blood vessels, nerves, etc. And some loose connective tissue is also present. This part is known as the medulla of the ovary. Okay, understood? Next, see how will you differentiate between different follicles, that you have to know. So this is asked also in your viva. Okay. So first, this is germinal epithelium. Beneath it is the tunica albuginea. Then you see this primordial follicles. Okay, primordial follicular cells, where it will contain one nucleus, and the lining epithelium is flattened. Okay, squamous type. Then after some days, it will develop into primary follicles. Primary follicle, it has a nuclei and there is zona pellucida will develop and it will be lined by cuboidal cells. You can see prominent rounded nuclei. Here it was squamous epithelium for primordial follicle, and for primary follicle it is having rounded nuclei with cuboidal epithelium. Okay. After that, when it is maturing, it will form the secondary follicle. This is the ovum, and these are the granulosa cells. They will form the corona radiata around the ovum, and these are the granulosa cells. They will form the theca interna and theca externa. Okay. Now it will develop into Graafian follicle. Here one antrum is developing, antrum will increase in size and fill almost whole of the follicle, and these are the outer granulosa cell lining, theca interna and externa, and here is the cumulus oophorus. Okay. Okay, next. After the ovulation, it will develop the corpus luteum. Okay, this granulosa lutein cells, they will develop into, and these are the granulosa lutein cells, and these are the theca lutein cells. Granulosa cell layer will develop into granulosa lutein cells. Theca cell layer, theca interna and externa, that will develop into theca lutein cells during formation of corpus luteum, and in the center there is blood clot. Okay. And it will, after some days, it will be degenerating and it will form the corpus albicans. Okay, no cell boundary, you can see the degenerating cells. Next, this is the structure you will see under the microscope. That was schematic picture, okay, or of HE staining And this is the structure you will see under the microscope. This is panoramic view. Panoramic view meaning it is showing whole of the ovary. All these structures you will not see together. Some part you will see, some part you have to move the field to see whole of it. Okay. So in the middle part there is the medulla, outer part is the cortex, outer lining is the germinal epithelium. You have to see it properly in high power view to see it properly. This is low power view. Okay. See, these are the follicles. Okay, smaller one are the primordial follicle. They develop into primary follicle, secondary follicle. Okay, these are one secondary follicle, mature follicle, and after ovulation, this corpus albicans is developing. Corpus luteum and then corpus albicans. Next. So. This is primordial follicle lined by squamous cells, primary follicle lined by cuboidal follicular cells, secondary follicles lined by multi-layered follicular cells, and this is tertiary follicle. Here the follicular antrum cavity filled with fluid. Antrum fluid has been started developing. This is cumulus oophorus portion of the granulosa cell. Okay, and this is stratum granulation. Outside it will be the theca cells, theca interna and externa. Next, this is a mature ovarian follicle. So it is develops primordial, then primary, then secondary, tertiary. Tertiary, when it matures, it will develop into mature Graafian follicle. Antral cavity has increased in size. Okay. So it is the antral cavity containing antral fluid. This is oocyte lined by the cumulus oophorus. This part is known as viscous polygerus. This is membrana granulosa, then theca interna, theca externa, okay, and this is the myometrium or endometrium tissue within which the ovum is embedded. Okay, or this is before ovulation. This will be the ovarian tissue within which it is lined. Okay, next. After ovulation, the ovum will look like this. There is female pronucleus, ooplasm. This oval one is the nucleus. This is ooplasm, and this is the first polar body. First meiotic division has occurred. Okay, reduction division, and it is lined by this layer that is known as zona pellucida. Okay, and it is lined by this corona radiata cells. So spermatozoa have to penetrate through these layers. This corona radiata, zona pellucida to enter into the ooplasm for fertilization with this female pronucleus. Okay, next. So these are the different stages of development, and these are the days of menstrual cycle. Okay, at the 14th day, generally on an average 28 day cycle occurs. Okay, it varies from 28 to 30 or 26 to 30, you can say. So at the 14th day almost the ovulation is occurring, and this period, this 0 to 14th day is the follicular phase because here the follicles are developing, and this is secretory phase. Okay, here the corpus luteum is formed, progesterone is secreted. Okay, and uterine glands are also become tortuous and secretion increases. That's why secretory phase. Okay, so these are the follicular development. You see primordial, primary, then secondary, multiple layer cells, tertiary, antral follicle, then Graafian, mature Graafian follicle, then ovulation is occurring, ovum is going out, then corpus luteum is formed, it is degenerated to form the corpus albicans. And this period, this 14 days is fixed. This period is varying in different length of menstrual cycle. Okay, follicular phase may vary, but secretory phase is always 14 days. Okay, understood? Next. Okay, so ovarian cortex shows various stages of developing follicles: primordial, secondary, primary, Graafian follicle, corpus luteum, corpus albicans, and atretic follicles. And this is oogenesis we are discussing. Oogenesis have been discussed in your embryology. Oogenesis comes and may come as a soft note. You need to discuss this here, or it has been discussed already. Oogenesis হয়েছে তো এমব্রায়োলজিতে লেকচার ক্লাসে হয়নি? হয়েছে? কি ডিসকাস করব কি করব না? ওকে। Okay, so first we will see the oogonia. Oogonia are primordial germ cells. It gives rise to oogonia before the birth of the female, in fetal life of the female. Oogonia multiply mitotically. They enlarge and form the primary oocytes. The primary oocytes complete the prophase 1 of meiotic division and get arrested at dictotin or diplotin stage at birth of the fetus by oocyte maturation inhibitor factor till the puberty. Till the puberty, it remains as primary oocyte. Okay? Out of 2 million primary oocytes, 4 lakhs persist up to the puberty and only 500 ovulate. Okay, these numbers are important. Numbers are asked in your MCQs. Okay. From birth to puberty, follicles remain in dormant stage. Next. Next is primordial follicle. They are located just beneath the tunica albuginea and the cortex of the ovary. Consists of oocytes and follicular cells. Oocyte is 30 micrometer in size and it has eccentric nucleus, cytoplasm and alveoli body. Okay. Next. Next is primary follicle. Primordial follicle enlarges and surrounded by follicular cells, proliferate and become cuboidal to form the primary follicle. You have seen in the picture. And here zona pellucida will be present. Membrana granulosa cells or stratum granulosum. These are cuboidal cells and surrounding stromal cells differentiate into theca interna and theca externa. Theca interna, it is inner highly vascular layer of cuboidal cells, and theca externa, this is outer connective tissue layer, consists of smooth muscle cells and bundle of collagen fiber. Okay. Here interna consists of highly vascular layer of cuboidal cells. Okay. And bundle of collagen fiber. Next. Next is secondary follicle. With the growth of the follicle, the granulosa cells proliferate and fluid-filled cavities starts appearing among these cells. And these small cavities fuse to form a large fluid-filled cavity called the antrum. And this fluid is called like follicular. Okay, antral fluid. And this follicle with antrum cavity is called the secondary follicle. Okay. Oocyte enlarges up to 125 micrometer in diameter and its further growth get arrested by oocyte maturation inhibitor secreted by the granulosa cells. Cumulus oophorous layer, it is lying around the oocyte and card external bodies is sometimes found. Okay. Next. Next is Graafian follicle. Diameter is 10 millimeter or even more. Okay, this is important. This diameter 10 millimeter. If this Graafian follicle, it continues to mature. Okay, it does not ovulate and continues to mature. That is diameter bigger more than 10 millimeter. You can consider it as a cyst. Okay, PCOD morphology. You can see polycystic ovarian disease. Multiple follicles are developing. It is becoming more than 10 millimeter in diameter. Okay, so that will turn into PCOD morphology of the ovary. And the primary oocyte completes its first meiotic division to form the secondary oocyte with first polar body. Follicular antrum increases in size and granulosa cells of cumulus oophorus surrounding the oocyte form a layer called the corona radiata. Theca interna cells secrete androgens, whereas granulosa cells convert this androgen into estrogen. Okay. And the granulosa cells proliferate under the influence of estrogen and increase the follicular size. Next. Next we go to ovulation. Ovulation is release of secondary oocyte from the Graafian follicle. Factor responsible for ovulation is increased volume of follicular fluid, plasminogen causing proteolysis of follicular cells, prostaglandin induce smooth muscle contraction of thicker external layer. Okay, these factors are causing ovulation. This is asked in your embryology or viva. Okay, and hormonal changes during ovulation. Just before ovulation, there will be LH surge, estrogen level also increases, progesterone lies at a very low level. Okay, so and macula pellucida or stigma. These after ovulation, the secondary oocyte is viable for 24 to 48 hours. This is also asked in MCQ. For how long this secondary oocyte is viable? Okay. If fertilization does not occur within this 24 or 48 hours, secondary oocyte degenerates. Okay. Secondary oocyte begins second meiotic division but get arrested at the metaphase and it completes second meiotic division only if it gets fertilized. Okay. Next. Next, after ovulation, you will see the corpus luteum or luteal gland. At ovulation, the follicle collapses and its wall becomes enfolded to form corpus luteum or yellow body. Cells of granulosa and thicker internal layers enlarge in size and get filled with lipid pigment called the lipochrome. It is yellow colored pigment. Cells of corpus luteum, granulosa luteum cells, they are large, centrally located cells. Thicker lutein cells are small, peripherally located cells, and granulosa lutein cells secrete progesterone, whereas thicker lutein cells secrete estradiol. And if fertilization does not occur, corpus luteum undergoes degeneration to form the corpus albicans. Okay, and if the fertilization occurs, pregnancy occurs, corpus luteum continues to increase in size. Okay, and it will increase release of secretion of the progesterone for maintaining the pregnancy until the placenta takes over. Okay, and cells of corpus lutein become swollen, thin, pycnotic, and get replaced with a scar of connective tissue after complete autolysis. And this white scar is called the corpus albicans. And the scar slowly sinks deeper into the ovarian cortex and disappears in several months. Okay. Next. Next, follicular atresia. Most of the ovarian follicles degenerate, undergo follicular atresia. And infants in follicular atresia, there will be initiation of apoptosis by granulosa cells, autolysis of granulosa cells by proteolytic enzymes, hypertrophy of thicker internal cells, replacement of follicular cells by connective tissue. These changes occur during follicular atresia. Next. So these are the flow chart of ovulation. First, before birth at puberty, and this is occurs after fertilization. So before birth of the fetus, female fetus, primordial germ cells migrate from yolk sac to gonadal ridge to develop the ovary. In the ovary, mitotic division occurs to form the oogonia. Oogonia divides to form the primary oocyte. Primary oocyte, it divides and first meiotic division occurs. Prophase 1, there will be arrest in the diplotin stage. Okay, and primary ovarian follicle develop. Then from its secondary ovarian follicle, tertiary ovarian follicle, Graafian follicle. Here meiosis 1 occurs. Meiosis 1 is completed here. Okay, here prophase 1 is occurring in the fetal life only. After that, arrest occurs here, and here at puberty, meiosis 1 is completed, developing into secondary oocyte and first molar body. Okay. And after fertilization only, meiosis two occurs. Secondary oocyte and secondary polar body is developed. So this is how oogenesis occurs. It comes as a short note or a part of a long question. Okay. Next. See, this is how primordial and primary follicles will look like. See, these are the primordial follicles. See, lined by the flattened nuclei, you can see for the squamous epithelium. This is hyper view of the HE stained slide of ovary, okay, of the cortex. So these are the primordial follicles, and here this follicle is lined by cuboidal cells. You can see rounded nuclei. Okay, so this is primary follicle. Next, now this is maturing follicle. This is ovum. It is lined by the zona pellucida. This is female pronucleus. Here, these are the cumulus oophorus. Okay, corona radiata cells. Here will be the discus proligerus. These are the granulosa cells. Here is theca interna, and this muscle layer is included within the theca externa. Okay, and this is antral cavity containing the antral fluid. Okay, this diagram you practice on schematic diagram of this mature follicle. Okay, next. This is photomicrograph of corpus luteum. Okay, hyper view of corpus luteum. See, theca lutein, theca interna and externa will develop into theca lutein cells, and granulosa cells will change into granulosa lutein cells containing yellow pigment, and outer side covered by the connective tissue, and antral cavity is developing into the follicular cavity. Okay, and hemorrhage, it contains hemorrhage fluid. Next. Okay, so this is in short histology of the ovary. It is lined by germinal epithelium, simple cuboidal epithelium. On the inner aspect, there you will see tunica albuginea, connective tissue layer, then outer cortex containing ovary and follicles. Then inner medulla will contain connective tissue, vessels, and nerves. Okay, and ovary and follicles are primordial follicle. It contains the primary oocyte and flat follicular cells. Then primary follicle, it contains primary oocyte, zona pellucida, and cuboidal follicular cells. Secondary follicle, it contains primary oocyte, granulosa cells, theca interna and externa. Graphian follicle or mature Graphian follicle, secondary oocyte, first polar body, corona radiata, cumulus oophorus. Then corpus luteum contains luteal cells with lipid pigments, and then corpus albicans, small fibrous mass. Okay. Graphian follicle, ovulation is occurring, ovum is released, it will form corpus hemorrhagicum. Follicle filled with blood. Then it will gradually develop into corpus luteum. Okay, progesterone secreting structure. Next, this diagram you have to draw in your histology copy. See, this is the germinal epithelium. Underneath, it is lying on a basement membrane. Okay, germinal epithelium. This is the tunica albuginea layer containing loose connective tissue. Then here are the primordial follicles. This is primary follicle lined by cuboidal cells. This is secondary follicle, multiple layers of granulosa cells. Okay. Then this is tertiary follicle, internal cavity has developed, theca interna, externa have developed, and this is mature Graphian follicle. Antral cavity has increased, all the structures are mature. Okay. After that, after the release of the ovum, it is developing into corpus luteum and corpus albicans. This is atretic follicle, means corpus albicans. So this part is the showing the cortex. This is cuboidal epithelium or germinal epithelium, then tunica albuginea, then cortex, and this part is showing the medulla. Here you can see sections of blood vessels, okay, and nerves. So this diagram you have to draw. Next, write down these 2 points. Outer cortex shows ovarian follicles in different stages of development: primordial, primary, secondary, and Graphian follicle. And inner medulla contains connective tissue with blood vessels. Okay, so you in your histology copy you draw this diagram and write these points. And in your spotter slides, during your exam you have to write down these ID points. You have to identify the slide and write down these 2 points of identification. Okay, understood? And prepare ovary as your short note. Okay, practice this diagram. In theory paper it can also come. And oogenesis also you prepare as a short note. Understood? Next. Okay, this is a picture from your atlas. See, these are the different follicles: primary follicles, secondary follicles, mature grafted follicle, this corpus luteum or hemorrhagicum. This part is albicans. Okay, recent albicans, and these are the old albicans, athletic follicles, degenerating follicles. This part is the cortex, and this part is medulla. Okay, understood? Next, अच्छा previous আগেরটাই যাওয়ার পর see this is the lining epithelium, germinal epithelium. Beneath it is the tunica albuginea. Tunica albuginea you can see clearly, and some sections of blood vessels are also present here. Next. Okay, so different follicles. These are the antral cavities. This oocyte. Okay, like this also you can see under the microscope. These are different follicles in the cortex. Next, mature follicle. Theca. These are the theca lutein cells called a corpus luteum section. Okay. Next, so different follicles: primordial, primary, secondary. Okay. Next. Okay, their interstitial fluid cavity is appearing. Okay, within the follicle, and this is ovum, corona radiator cells. Next, this is the oocyte lining this say granulosa cells. Okay, these are the smaller follicles, primordial, primary follicles, and this is one athletic follicle. Next, corpus luteum will look like this. Next, okay, within the corpus luteum, these are the theca lutein cells. They are light staining. Okay, they are the surrounding area. Okay, theca lutein cells are deep staining, but granulosa lutein cells are light staining. Okay, and next, okay, that's all. Okay, so you have to see the ovary, germinal epithelium, tunica albuginea, cortex. Within the cortex, different types of follicle and medulla. Okay, so make a Q, go to the microscope. Okay, next, on the this side, right, left upper part. This is the outermost covering. You will see germinal epithelium. Okay, beneath it some connective tissue, and within it, then you will see the cortex of the ovary. Within the cortex, multiple size follicles. You will see some follicles are maturing and containing the antral cavity containing fluid. And on this side, lower down on the right side, you will see one mature follicle. Okay, containing large amount antral fluid, and if you change the field on the right lower part, you will see the medulla. Okay. So you see here, এটা ভালো আছে, দেখ এটা ভালো বোঝা যাচ্ছে, দেখ একদম নিচে এইভাবে আছে। ওকে, লাইক দিস, ফোকাসই ছিল না তো এটা। ও আচ্ছা, ঠিক আছে, থ্যাংক ইউ। ওকে, এইভাবে দেখ একটা লাইন আছে বাইরে পুরো সাদা, ওই লাইন, দিস লাইন উইল বি দা জার্মিনাল এপিথেলিয়াম। তার নিচে টিউনিকা অ্যালবুজিনা, দেন ছোট ছোট অনেক ফলিকলস আছে, প্রাইমর্ডিয়াল, হ্যাঁ কর্টেক্সে, কর্টেক্স রিজনে প্রাইমর্ডিয়াল, প্রাইমারি এগুলো আছে। তারপর একটা বড় আছে দেখে দি ম্যাচিওর ফলিকল পুরো। তারপর আর এই দিকটাই আছে দেখ মেডালা, ব্লাড ভেসেলস এর অনেক সেকশন এবং কানেক্টিভ টিস্যু। এটা দেখ, হ্যাঁ সেন্ট্রাল পার্টে, হ্যাঁ দেখ এটা ওই ওভিউলার আছে ওরকম বোঝা যাচ্ছে, আর সেকশনস আছে দেখ। ওকে, আর এইটা কর্পাস লুটিয়াম একটা এই জায়গাটাতে বুঝতে পেরেছো সবগুলো আছে সেকশনে আর এই লুটিয়াম আর এই সাইডটাতে আরো যদি ফিল সরা সেই দিকটায় কানেকটিভ টিস্যু দেখতে পাবে ওটা হচ্ছে মেডালা
Today our topic is liver. Okay, gross anatomy of liver. So before starting the anatomy, let's start. At first, what is the location? Tell me what is the location of liver? So this is if you are dividing the abdomen into 9 quadrant, right? How many quadrant we will get? At first tell me what is the first horizontal line? প্রথম horizontal line টা কি? Transpyloric plane. Okay, so this one is the transpyloric plane.
Disconnected. Connected.
Okay, and second one is that is what it is? The second one, transtubercular plane. Okay, it is also known as linea semicircularis. Okay, so this is the transtubercular plane.
Disconnected.
Okay, so these are the two plane, and again we will
Connected.
divide two vertical line. How we are getting the vertical line? So that is the mid clavicular line. So you are having two. So how many region we are having? First one is the right hypochondrium, then this one is the epigastrium, then the left hypochondrium, then this is the
Disconnected.
right lumbar, this one is the umbilicus, this is the left lumbar, and this one is the right iliac, hypogastrium, and the left iliac. Okay, so what is the situation of liver? So it occupies কি occupy করে mainly right hypochondrium, epigastrium, and another one is left hypochondrium. So write it down. The liver extend up to কোথায় কোথায় হবে? right hypochondrium. Why this locations is important? Suppose any patient come and having pain in that particular region, তাই তো? যদি ধর রাইট হাইপোকন্ড্রিয়াম আছে, ইট মে ইনভলভ কি ইনভলভ করতে পারে? ইট মে বি লিভার, ইট মে বি রিলেটেড টু গল ব্লাডার. Okay, if it is on the right iliac fossa, which organ we will look for? Appendix. Okay, if it is left iliac fossa, I said iliac fossa, left iliac fossa হলে কি হবে? Sigmoid colon. Okay, then above if you are going the left lumbar, so which viscera is related? Left lumbar. So see, anything pain on the kidney, pain would be felt on the posterior surface. Okay, not on the anterior surface. তাহলে left lumbar কি কি হতে পারে? It may related to spleen, it may related to the stomach. Okay, and epigastrium mainly occupying the stomach and also the duodenum. Okay, so if you have to think anything called hepatic, okay, any term related like hepatitis, hepatomegaly, okay, anything it is related, so that is related to the liver. Okay, so what is the location? Write it down. Liver located on right hypochondrium, epigastrium. Close the door. Then next one is the left hypochondrium. Okay, now what is the shape of liver? It is wedge shape. Write it down. It is wedge shaped organ. Okay, it is wedge shaped organ. Then what about the consistency? Have you seen the liver? What about the consistency? Write it down. It is soft and friable. Okay, it is soft and friable. Soft and friable. Okay, friable means it is easily cutted. Okay, easily it could be cutted. Okay, so that is the nature, okay, or the consistency. So write it down. It is soft and friable in consistency. Okay, then it is wedge shaped. Okay, what about the weight? For male and female it vary, right? So approximately weight would be 1.5 kg. আর কার 1.5 kg আছে বলেছি? Brain. Okay. So brain, see, brain is anyhow it is maintained by the skull, right? What about the liver? How it is hanged? So there are three factors. I will come across. There are three factors. So write it down. Weight of liver. Weight of liver in case of. Where is your notebook? So weight of liver in case of male it is about 1.5 to 1.8. Okay, 1.8 kg. And in case of female it is 1.2 to 1.6. Okay, 1.2 to 1.6. Okay, in case of female. Okay, now little bit about embryology. How does the liver develop? It's mainly developed from which mesogastrium? Ventral mesogastrium. It develops from ventral mesogastrium. Okay, and write it down. It is covered by key capsule ta naam, that is Gleason capsule. Very much important. Gleason capsule. Okay, so throughout if you see the liver in the gross anatomy you will found one fleshy covering. Okay, very thin fleshy covering, that is known as Gleason capsule. Okay, so liver is covered by like that. Okay, and how many term we are having in the words? 5. So letter 5 is about the liver. Okay, how many lobe it is having? 5 lobe. Write it down. Liver has got 5 lobe. So hope you could tell the 4 lobe, but what about the 5 one? So first one is the right lobe. Right lobe. Second one is the left lobe. Then what about the, so this is the anatomical lobe.
Connected.
Okay, so there is a difference between anatomical lobe and physiological lobe. Okay, so the third one is caudate lobe. Caudate lobe. Fourth one is quadrate lobe. What about fifth one? Who will tell fifth one? Occasionally only 2% cases we will get another lobe, that is known as Riddle's lobe. Okay, এটা MCQ আছে, Riddle's lobe. Fifth one is Riddle's lobe. Okay, in gray anatomy you will get this one. Okay, Riddle's lobe, এটা কত percent cases? Only 2% cases. Okay, so actually if somebody will ask how many lobe, you have to say anatomically 5 lobe. Okay, and physiologically is 8 lobe, that is known as coniate classification. I will come across on the clinical anatomy. Okay, liver. So this is about the lobe. Then next one is what are the factor? Which are the factor by which the liver is kept in position? Okay, which are the factor? কতগুলো factor আছে বল? So first one is hepatic vein. Okay, সব থেকে major factor কোনটা? Hepatic vein. Okay, so how does the liver look like? প্রথমে কি হবে? Rounded right lateral
Disconnected.
part. Okay,
Connected.
then above this one is going up to the where it is crossing the epigastrium, even it is going to the left hypochondrium. Okay, and from there if you see the inferior border, it is somewhat rough. Okay, so this is the liver. So liver has how many surfaces and how many border? So write it down. Liver has 5 surfaces. So again see, you are getting the 5 term. Okay, 5 surfaces. So which are the surfaces? First one is the anterior surface. Write it down. Anterior surface is also known as diaphragmatic surface. Okay, anterior surface is covered with diaphragm and also known as diaphragmatic surface. Okay, so first one is anterior surface of the diaphragmatic surface. Then coming the posterior surface. So posterior surface is also known as visceral surface. Why we are saying how many organs is related? Could you tell how many? As many as 7 organs. Okay, as many as 7 organs. Okay, posterior surface is also known as visceral surface. Then the next one is which surface? Superior surface. So superior surface is also known as, again it is related to the diaphragm. Okay, diaphragmatic surface, or also you could say costal surface. Okay, so which are the rib it is related to the liver? So you have to say 7 to 11. Okay, it will start from 7 and up to the 11 and all the intercostal spaces. Okay, so it is related to the these ribs. Okay, then coming which surface, that is known as lateral surface. Which lateral surface? Right lateral. So it has got only the right lateral surface. Okay, and which surface you forgot, that is the inferior surface. Okay, so it has got 5 surfaces: anterior, posterior, then superior, inferior, and the right lateral. Okay, now coming to the border. How many border it has got? Huh? Sudhumatro, you have got the inferior border, sharp inferior border. Okay, it has got sharp inferior border. Okay, so now I am telling which are the factor by how the liver is kept in right position. So first one is hepatic vein. How many hepatic veins are there? Right, left, and the intermediate. Okay, so there are 3 hepatic veins. So if you see the hepatic vein, how it is present, which structure is there in between? Which structure is bifurcating? Tell me which structure is bifurcating? That is the inferior vena cava. Okay, and liver is, suppose liver is present on the right side. Okay, so liver is present on the right side. So from there are how many hepatic vein? 2. And sometime another hepatic vein used to come, that is known as the intermediate hepatic vein. Okay, so anyhow liver is kept in position by this hepatic vein. This is the first factor. Then second one is intra-abdominal pressure. Second factor is intra-abdominal pressure. So why intra-abdominal pressure? When the intra-abdominal pressure raised, tell me sir. Will say
Connected.
কখন intra-abdominal pressure raised হয়? Lifting weights, coughing. Okay, these are the cases in case of parturition. Okay, intra-abdominal pressure is raised, but anyhow because of intra-abdominal pressure it is keeping pressure on the liver upwards, so it is kept on this position. Okay, and the third one is the ligament. Write it down. Next one is the which ligament? These are known as peritoneal ligament. How many peritoneal ligaments? No, now coming, tell me which are the true ligament, which are the false ligament. True ligaments is actually embryologically that are present. Understood? That are remnant of embryological life. বুঝা গেল? So which are the ligament? These 2 are the true ligament. Okay, and which are the false ligament then? Remaining যতগুলো আছে. So now we are coming, just write it down, peritoneal ligaments. Okay, so now we will discuss about ligaments of liver. Okay, so how many ligaments we are having? So first one is, and how it is present. So if you see the liver from the anterior surface, there is one ligament that is coming triangularly. Okay, and it is dividing the liver in between. Okay, so
It's
what is the
connected.
ligament? এই লিগামেন্টটাকে কি বলবো?
Connected.
This one is the falciform ligament. Okay, so first ligament is falciform ligament. Is it a true ligament? False ligament. Okay, so it is the derivative coming from the peritoneum. Okay, these are the peritoneal reflection that is covering the liver. Now this falciform ligament, if you see anterior aspect of the abdomen, it is divided into 2 sides. Okay, in the corner, what it is called? tell me two side, which are the two ligament? No, this ligament, triangular ligament. Okay, so both side, right side এটা কি নাম হবে? Right triangular. These are reflection coming from the falciparum ligament. So this one is the left triangular. Okay, and which are the other ligament? So if you see the coronary ligament, you have to take the posterior turn of liver. Okay, so if you see the posterior side, right side টা কোন দিকে যাবে বল? লেফটে চলে আসবে, এটা কিন্তু মাথায় রাখতে হবে, ঠিক আছে? তার মানে এই যে পিকচারটা আছে এটাকে যদি রিভার্স করি, হাউ ইট উইল লুক, কিরকম দেখতে লাগবে বল? এদিকটা হয়ে গেল রাইট ল্যাটারাল, ঠিক আছে? দেন এই সাইডে কি যাবে? এই সাইডে এরকম একটা গ্রুপ তৈরি হবে। ওকে, হাউ দিস গ্রুপ ইজ ফর্ম? এখানে বাই হুইচ স্ট্রাকচার? দ্যাট ইজ দ্য ইনফিরিয়ার ভেনা কাভা। ওকে, আইভিসি থাকে এখানে, ঠিক আছে? And at the lower surface it is looking like this. Okay, and most lower surface there is one organ that is hanging over here, that is the gallbladder. Okay, so how the falciparum ligament is coming? Both side, how it is coming? So these both side already I have discussed. This is the right and left triangular ligament. So this ligament on this side it is making like these two reflection. Okay, এই রিফ্লেকশনটাকে কি বলবো? towards the right, this is the right lobe. Okay, so that would be right coronary ligament. Okay, so this one is the right coronary ligament. Okay, and what is this? This is the left coronary ligament. Now what is happening? These two ligaments just inferior side of gallbladder, which side? Left side এর দিকে থাকবে, there is one reflection that is known as, এটাকে কি বলবো বল? লিগামেন্টাম টেরিস হেপাটিস। বোঝা গেল কোন সাইডে থাকবে? গল ব্লাডারের রাইট সাইডে থাকবে, ঠিক আছে? গল ব্লাডারের রাইট সাইডে থাকবে। সো দ্যাট ইজ দ্য লিগামেন্টাম। I told how many round ligament is there? How many round ligament is there? 3, তাই তো? First one is ফিমারে পড়েছিস, লিগামেন্টাম টেরিস ফিমোরিস কোথায় থাকে? হেড অফ দ্য ফিমার। দেন নেক্সট দিস ওয়ান লিগামেন্টাম টেরিস হেপাটিস, আর থার্ড ওয়ান ইজ রাউন্ড লিগামেন্ট অফ ইউটেরাস। কি বলবি? লিগামেন্টাম টেরিস ইউটেরাই। ওকে, সো দিস আর দ্য 3 রাউন্ড লিগামেন্ট। ওকে, সো দিস ইজ দ্য লিগামেন্টাম টেরিস হেপাটিস। সো দিস আর দ্য লিগামেন্ট। তার মানে কি কি পেলাম আমি? লিগামেন্ট, falciparum ligament, then left and right triangular ligament posterior surface elam, right and left coronary ligament, ligamentum teres hepatis. Again another reflection is coming over here, সেটাকে কি বলছি? ligamentum venosum. Okay, now see these two ligaments are remnant of embryological life. Okay, now tell me which are the remnant? কি কি remnant? এটা কার remnant? Which one? Left or right? How many times I told you? The left is left, right will disappear. তারা যদি remnant হয় কার হবে? Left এর হবে. Okay, so this one is the obliterated left umbilical ligament. Okay, obliterated left umbilical vein. Okay, so this is the remnant, so that is known as ligamentum teres hepatis. What about ligamentum venosum? Ductus venosus. Okay, so ligamentum venosum कार remnant? Ductus venosus. Okay, ductus venosus. ঠিক আছে, আর কার remnant আছে? I told you in fetal life, suppose one baby has born, which are the door that would be shut? একটার পর একটা shut হয় কেন? Because the action of placenta would be taken over by lungs, তাই তো? তাহলে কোন কোন ডোর গুলো ক্লোজ হবে? প্রথমে কে ক্লোজ হবে বল? রাইট ইট ডাউন। প্রথমে হবে আম্বেলিকাল আর্টারি, ঠিক আছে, প্রথমে ক্লোজ হবে। ফিটাল সার্কুলেশন পড়েছিস, পড়ানো হয়েছে ফিটাল সার্কুলেশন। সো জাস্ট গো থ্রু টুডে উইথ ফিটাল সার্কুলেশন। ওকে, সো প্রথমে কি ক্লোজ করবে? আম্বেলিকাল আর্টারি। তারপর কি ক্লোজ করবে? আম্বেলিকাল ভেন, ঠিক আছে। তারপর কি ক্লোজ করবে? ওপরে উঠছে আস্তে আস্তে, ঠিক আছে। আম্বেলিকাল আর্টারি, আম্বেলিকাল ভেন কোথায়? ইজ এ কম্পোনেন্ট অফ আম্বেলিকাস। হুইচ আর দ্য আদার কম্পোনেন্ট অফ আম্বেলিকাল কর্ড? টেল মি দ্য কন্টেন্ট অফ আম্বেলিকাল কর্ড, কি কি থাকে? 2 umbilical artery, 2 umbilical vein, and allantois and vitalointestinal duct. So you have to say AQ VQ, ঠিক আছে, A3 V3, ঠিক আছে। So these are the content of umbilical cord যদি cross section করি, so you will get these are the content of umbilical cord. Okay, so what I am telling, প্রথমে কি ক্লোজ হবে? umbilical artery, then umbilical vein, then তারপর কি ক্লোজ হবে? this one, that is ductus venosus. ডাকটাস ভেনোসাস, লিগামেন্টাম ভেনোসাম বলবো না, বিকজ উই আর কনসার্ন অ্যাবাউট ফিটাল লাইফ, ঠিক আছে। ডাকটাস ভেনোসাস। নেক্সট কি হবে? ডাকটাস আর্টেরিওসাস। নেক্সট ওয়ান ইজ ডাকটাস আর্টেরিওসাস। কোথায় থাকে রে? ওয়্যার ইউ উইল গেট ডাকটাস আর্টেরিওসাস? ডেভেলপমেন্ট অফ হার্ট ইজ ওভার। কোথায় আছে? হ্যাঁ, ডাকটাস আর্টেরিওসাসটা কোথায় থাকে? হার্টে থাকে তো, যেটা মেজর ভেসেল গুলো থাকে তার মধ্যে থাকে। কোনটাতে থাকে? বিটুইন দ্য পালমোনারি আর্টারি অ্যান্ড দ্য আর্চ অফ অ্যাওর্টা, ইটস এ কানেকশন। ওকে, সো সেটাকে কি বলবো? ডাকটাস আর্টেরিওসাস। আর লাস্টে কি ক্লোজ হবে? দ্যাট ইজ দ্য ফসা ওভালিস। বোঝা গেল? হ্যাজ টু বি ক্লোজড। ওকে, whatever congenital anomaly you will get, it will due to either PDA, patent ductus arteriosus, ঠিক আছে, or there would be foramen ovale, তাই তো? এই কারণে these are the congenital heart disease. Okay, so these are the remnant of the membrane. Okay, so next we will come across, this is the ligaments of liver. Okay, then coming, write it down, diaphragmatic surface or anterior surface. One by one surface we will go. So first one is diaphragmatic surface or anterior surface. So it is related to the diaphragm, okay, and posterior surface or visceral surface. If you say posterior surface or visceral surface, I told how many organ it is related? 7 organ. So one by one we will come. তাই তো? রাইট সাইড এবার which are the organ? First impression you will get on the left side. So if you divide this liver, so this is the posterior surface. So if you divide the liver into right and left, okay, so towards the left which are the impression you will get? প্রথম impression কি পাবি? Esophageal impression. So write it down. First impression is the esophageal impression. ওকে, সো ফার্স্ট ইমপ্রেশনটা কোথায় পাবি? এই জায়গাটা করে পাবি। ওকে, সো সাপোজ দিস ইজ দ্য ইনফিরিয়র ভেনা কাভা অ্যান্ড দিস ইজ দ্য লিগামেন্টাম ভেনোসাম, পুরোপুরি যাচ্ছে, ঠিক আছে। সো হেয়ার ইউ উইল গেট ফার্স্ট ইমপ্রেশন, যেটা এইভাবে আসছে, এটাকে কি বলবো? গ্যাস্ট্রিক ইমপ্রেশন। ওকে, গ্যাস্ট্রিক ইমপ্রেশন। অ্যান্ড হেয়ার ইউ উইল গেট, এই জায়গাটাকে কি বলবো? ইসোফেজিয়াল ইমপ্রেশন। So this one is the esophageal impression, this one is the gastric impression. So stomach টা এইভাবে esophagus টা এসে stomach টা আসছে, right? So this area, এই এরিয়াটা কি থাকবে তাহলে? Pyloric impression. So this one is the pyloric impression. Okay, then towards this side on the left, this is the right side. So left side এ কাকে পাবো? এই এরিয়াটা কি পাবি? ডুওডিনাল ইমপ্রেশন। দেখ এইভাবে পাইলোরাসটা এসে এইভাবে ঘুরবে কিনা, ডুওডিনামে ওইভাবে যাবে। গল ব্লাডারটা এই জায়গাটা করে আছে, রাইট? তো এই জায়গাটা হচ্ছে ডুওডিনাল ইমপ্রেশন। ওকে, অ্যান্ড টুয়ার্ডস দিস সাইড এখানে আরেকটা ইমপ্রেশন পাবি, দ্যাট ইজ নোন অ্যাজ সুপ্রারেনাল গ্ল্যান্ড। হুইচ সুপ্রারেনাল? রাইট সুপ্রারেনাল। সো রাইট ইট ডাউন অন দ্য লেফট সাইড, দুটো কলাম কর। অন দ্য লেফট সাইড কি কি রিলেশনে আসবে? ফার্স্ট ওয়ান ইজ দ্য ইসোফেগাস, Okay, first one is esophagus, second one is gastric impression, okay, third one is pyloric impression, okay. These are the impression on the left side, okay. Now coming to the right side, first impression কি পেলাম, duodenal impression, okay. Then you are having right suprarenal gland, RSR লিখলাম, ঠিক আছে, right suprarenal gland, আর এই এরিয়াটায় কি থাকবে তাহলে, no, this area is colic, এই এরিয়াটা কি থাকবে, রাইট সুপ্রারেনাল যদি হয় এটা হবে রাইট কিডনি, ওকে, রাইট কিডনি, and on the inferior surface you are having colic impression. Which colon, which part of colon, যেটা আমরা বলি হেপাটিক ফ্লেক্সর, তাই তো, রাইট কি বলে ওটাকে, রাইট হেপাটিক, রাইট ইট ডাউন, right colic flexure, right colic flexure or the hepatic flexure. Left টাকে কি বলবো, splenic flexure, কোনটা উপরে থাকে, কোন ফ্লেক্সারটা, transverse colon is not a parallel one, which one is above, splenic, কারণ this side is liver, okay, তাহলে যেটা right side এ hepatic flexure that would be related, okay. So the visceral relation, see how many we are getting, কতগুলো পাচ্ছি, stomach number 1, প্রথমে কোন অর্গান আছে, stomach, দেখ 7টা কি করে হচ্ছে, আমি 7টা বলেছি, ঠিক আছে, স্টমাক হলো, দেন সেকেন্ড ওয়ান ইজ ইসোফেগাস, না পাইলোরাস তো স্টমাকেরই পার্ট, ঠিক আছে, পাইলোরাস ইজ এ পার্ট অফ স্টমাক, তাই না, তাহলে ওটাকে নেক্সট ওয়ান কি থাকবে, স্টমাক ইসোফেগাস হলো ডুওডিনাম, ওকে, ডুওডিনাম, আচ্ছা এবার 4 নম্বর বল, রাইট সাইডে চলে যাচ্ছে, তাহলে রাইট সাইডে প্রথমে হবে রাইট সুপ্রারেনাল গ্ল্যান্ড, সুপ্রারেনালকে আগে বলতে হবে কারণ কিডনি অলরেডি ওকে সুপিরিয়রলি বসিয়ে রেখেছে, ঠিক আছে, সুপ্রারেনাল গ্ল্যান্ড, দেন ফিফথ ওয়ান ইজ রাইট কিডনি, ঠিক আছে, সিক্সথ ওয়ান ইজ হুইচ কোলন, রাইট কোলিক ফ্লেক্সর, রাইট কোলিক or you could say hepatic flexure, both are correct. তাহলে 7 নম্বরটা কি, gallbladder is a also viscera but it is related to liver only, it is a part of liver, it hang on the inferior, posterior inferior surface of liver. So which is the 7th organ, হ্যাঁ, bear area, মানে সেখানে কেউ বললি একটু ভুল হলো, but very good. 7th one is pancreas, but which part, head of pancreas, okay. So কি জানো তোর নাম, সুব্রনীল, তাই তো, so this is pancreas, head of pancreas, ঠিক আছে, head of pancreas. এবার head of pancreas টা কোথায় থাকে, দেখ এই পুরো এরিয়াটাকে আমি গ্যাস্ট্রিক ইমপ্রেশন বললাম, রাইট, বাট ইফ ইউ সি দ্য পোস্টেরিয়র সারফেস ইউ উইল সি হেয়ার ওয়ান এলিভেটেড পার্ট, ঠিক আছে, এই এরিয়াটা একটু এলিভেটেড আছে, ওকে, সো দ্যাট ইজ নোন অ্যাজ টিউবার ওমেন্টাল, ওকে, টিউবার ওমেন্টাল, এই এরিয়াটাকে বলছে টিউবার ওমেন্টাল, and it is related to what I told, it is related to head of pancreas, it is related to head of pancreas, okay, and you will also get tuber omental, আর কোথায় পাবো, in the pancreas also, okay, if you study the pancreas we will get tuber omental in the pancreas also. Now the question is which structure is between the pancreas and the liver, tuber omental যে সারফেসে আছে that is related to pancreas, so posteriorly liver আছে, anteriorly pancreas আছে, head of pancreas আছে, so I am asking which structure is in between, which layer of peritoneum, that is known as lesser omentum, write it down, lesser omentum, okay. So if you see the lesser omentum, how many layer it has got, কটা লেয়ার আছে বল, দুটো লেয়ার, how many ligament it is forming, it has got 2 layer, greater omentum has got 4 layer because it fold on itself, but lesser omentum has 2 layers, but it has got 2 ligament that is connecting liver with stomach and liver with duodenum. তাহলে দুটো লিগামেন্টের কি কি নাম? একটা হচ্ছে হেপাটো গ্যাস্ট্রিক লিগামেন্ট আর একটা হচ্ছে হেপাটো ডুওডিনাল লিগামেন্ট. So this is nothing but the part of lesser omentum. Okay, so first one is কি বললাম? Gastrohepatic or hepatogastric, whatever you say. Okay, and the second one is hepatoduodenal. এবার just tell me which are the ligament, these two are the ligament, how it is attached to the posterior surface. কোথায় থাকবে? এই যে গ্যাস্ট্রিক এরিয়া ইউ আর সিইং, এখানে কোন লিগামেন্ট থাকবে? দা হেপাটোগ্যাস্ট্রিক লিগামেন্ট থাকবে। আর এখানে যে ডুওডিনাম আছে এখানে কোন লিগামেন্ট পাবো? দা হেপাটোডুওডিনাল লিগামেন্ট। So these are nothing but the reflected part of lesser omentum. Understood? So this is on the posterior surface. Okay, so rather than posterior surface we will come across to the bare area. Okay, so write it down, bare area of liver. Bare area, what do you mean by bare area? These are devoid of peritoneum. Write it down, bare area. Bare area কিন্তু short note এ আসতে পারে. Okay, so how many bare area? These area are devoid of peritoneum. একটু পরে, devoid of peritoneum, and there are 5 bare areas. There are 5 bare areas on the liver. Okay, so number 1 bare area কোনটা এবং কোথায় পাবো? যেটাকে বলে দি বেয়ার এরিয়া। কোন সাইডে, রাইটে না লেফটে? এই সারফেসটা, ইফ ইউ সি দিস সারফেস, ঠিক আছে, posteriorly, superiorly, if you see that area is devoid of peritoneum, and this is known as, এটাকে কি বলছে, দি বেয়ার এরিয়া। Okay, and you know it is one of the site for, already বলা হয়েছে, it is one of the site for portocaval anastomosis, right? So tell me how many surface we are having portocaval anastomosis? কতগুলো সারফেস আছে? First one at the lower end of esophagus. Okay, second one is the porpor eye, porpor lengthwise eye. প্রথমে হচ্ছে esophagus, then second one is bare area of liver, then the third one is umbilicus, that is known as caput medusae, then you are going to posterior abdominal wall, and the fifth one is the hemorrhoids. বোঝা গেল? These are the 5 area for portocaval anastomosis. So one of the area you have to remember, that is the bare area. এখানে কেন bare area বলছি? Tell me which are having the anastomosis over here, bare area. This is one of the site of portocaval anastomosis, na? Means anastomosis between systemic vein and the portal vein. তাহলে এখানে কোন ভেন আছে? হেপাটিক ভেন থাকবে, সেটা সিস্টেমিক হয়ে গেল। আর পোর্টাল ভেন কোনটা? পোর্টাল ভেনের ট্রিবিউটারি কোনটা? So there is central vein. Okay, central vein you are having, and hepatic vein. Okay, so that is one of the site for anastomosis. The bare area যদি বলে। Next bare area কি আছে? So first one হয়ে গেল bare area, the bare area। তাহলে the bare area বুঝতে পারলে কোন জায়গাটায় আছে। Then second one is, what about the second one? Groove for inferior vena cava. Okay, next one is groove for inferior vena cava. So এখানে কি হয়, if you see the posterior part, if we go through the posterior part of liver, we will see inferior vena cava is there, but above there is layer of peritoneum. তাহলে যে জায়গাটা inferior vena cava আছে, that is devoid of peritoneum. Understood? Because it is covering which organ? Inferior vena cava. So it is directly attached to the liver. So that is also second area, the bare area. Then third one is, 3 নম্বর কি আছে? না, থার্ড ওয়ান fossa for gallbladder. যেখানে gallbladder হ্যাং করে আছে, if you see that area also, that is also devoid of peritoneum. Okay, so next one is fossa for gallbladder. Then what about fourth one? এখানে একটা এরিয়া আছে, that I will come across, that is known as porta hepatis. Okay, porta hepatis. So fourth one is porta hepatis, and And what about the fifth one? That is groove for ligamentum venosum. Groove for ligamentum venosum. তার মানে এই জায়গাটা যেখানে লিগামেন্টাম ভেনোসাম পুরো গ্রুপটা তৈরি করছে। সো গ্রুপ ফর লিগামেন্টাম ভেনোসাম। Okay, so these are the 5 area that is devoid of peritoneum. Okay, so this is known as bare area. Okay, next one we will come across the lobe. Okay, liver is so much long subject, so many small fragment it has got. Okay, so next one we will come across, that is lobes of liver. Okay, so first we will discuss about the right lobe. Okay, so how this right and left lobe is demarcating by the falciform ligament, and the right lobe, if you see anteriorly, it is taking the largest part, right? That means it is also taking the right hypochondrium, it is also taking the epigastrium. আর লেফটে শুধুমাত্র লেফট লোব আছে, লেফট হাইপোকন্ড্রিয়ামে। ওকে, নাও কামিং টু দ্য পোস্টেরিয়ার সারফেস। ওকে, সো পোস্টেরিয়ার সারফেস, নেক্সট উই উইল কাম অ্যাক্রস দ্য কর্ডেড লোব। ওকে, সো কর্ডেড লোব কোন জায়গাটায় থাকে? কোথায় থাকে বল? ইনফিরিয়ার ভেনা কাভা। হোয়াট ইজ দ্য demarcation? So this is the liver. So if you see on this side, that is the inferior vena cava. First যেটা পাবি সেটা হচ্ছে inferior vena cava. It is making the groove. Okay, and over here on the middle of the surface you are having 3 vessels. Okay, so that is also known as কি বলে সেটাকে? porta hepatis. Okay, so this is the site some structure will enter and some will emerge from liver. So which are the structure porta hepatis? So you have to trace anterior to posterior. ঠিক আছে, anterior to posterior কিরকম রিলেশন হবে? DAV. ওকে, anterior to posterior if you see, তো ফার্স্ট ওয়ান কি হবে? তো এই দিক থেকে এদিকে যাচ্ছি, তাহলে ফার্স্ট ওয়ান ইজ hepatic duct, then next one is
Connected.
hepatic artery, then next one is which vein? Portal vein. Okay, so this thing you have to remember, this is the portal vein, right? Now if you say posterior to anterior, what would be the relation? Just opposite, VAD. So you have to be very careful what they are asking in the question on the MCQ. Okay, anterior to posterior or posterior to anterior. So now tell me which things are entering to the liver? কোন জিনিসগুলো এন্টার করছে লিভারে? So liver is supplied by, I told, one by the portal vein and hepatic artery. But how the percentage? যেমন ধর আমি বলি যদি হার্টে রাইট করোনারি আর্টারি কত সাপ্লাই করে? 60%, আর লেফট করোনারি কত করে? 40%। লিভারে কি করে সাপ্লাইটা হয়? পোর্টাল ভেন করে 80%, 75 to 80%. Okay, and remaining 20% by the hepatic artery. And hepatic artery is a branch of, now you studied. So it is a branch of celiac trunk. Okay, one of the branch, common hepatic artery proper. So it is giving 2 artery, right hepatic and left hepatic. So this is the hepatic artery that is entering. Portal vein that is entering. Which one is coming outside? That is the hepatic duct. Which thing is coming through this duct? Bile. So bile is produced from কত পার্সেন্ট? 89% by the liver. Okay, remaining by the gallbladder. Okay, but actually this bile is stored where? On the gallbladder. That is the main function, but it is produced on the liver. Okay, so you have to know which thing is emerging out. Ektai structure ache, that is the hepatic duct. Okay, so why we are concerned about porta hepatis? So you have to tell about the corded lobe. So what are the boundary? Superiorly ki pacchi? Superiorly we are having inferior vena cava. Okay, then if you are coming towards the right side and left side, tell me the boundary. Ligamentum venosum কোন সাইডে থাকবে? রাইট সাইড, এই সাইডে থাকবে ligamentum venosum. ওকে, দিস সাইডে থাকবে ligamentum venosum. ওকে, And what about this side? Inferior side is covered by the porta hepatis. Okay, so just write down superiorly chordate lobe boundary superiorly by the inferior vena cava, inferiorly by the porta hepatis, inferiorly by the porta hepatis, and both side there is groove for ligamentum venosum, groove for ligamentum venosum. So what about the chordate lobe? Chordate lobe ta kon jayagaয় থাকে? It is quadrilateral. Okay, this is known as chordate lobe. So what are the structure you will get? Boundary wall superiorly by the porta hepatis, and below which organ is there? Gallbladder. Okay, so write it down. Superiorly porta hepatis, superiorly porta hepatis, inferiorly fossa for gallbladder or gallbladder you could say. Okay, আর এই সাইডে কি আছে? Fissure for ligamentum teres hepatis. Fissure for ligamentum teres hepatis. Okay, so this is the boundary for quadrate lobe. Okay, and radius lobe, if it is found, it would be found on the posterior side. Okay, so what is happening between the quadrate and quadrate lobe? You are getting another small lobe. Okay, so that is known as radius lobe. You will get 2% cases. Okay, so now coming to the physiological lobe. Write it down. Physiological lobe. What is the classification known as? C দিয়ে কি? Cornier's classification. Cornier's classification. Okay. So what is that Cornier's classification you are having? We are having 8 lobes of liver. How we are dividing? Tell me how we are dividing? Right lobe. So right lobe, how it is divided? No, at first you have to say anterior and posterior. So at first write it down. The right lobe is divided into so right lobe is divided into anterior and posterior. What about the left lobe? এরকমই একটা ক্লাসিফিকেশন আর কোথায় পেয়েছি? এরকম টাইপের একটা ক্লাসিফিকেশন কোথায় পেয়েছি? পালমোনারি ব্রঙ্কোপালমোনারি সেগমেন্টে পেয়েছি। ওকে, সো উই আর হ্যাভিং রাইট লোব, দেন দ্য লেফট লোবটা কি করে ভাগ হচ্ছে? মিডিয়াল অ্যান্ড ল্যাটারাল, মিডিয়াল অ্যান্ড ল্যাটারাল, এটাই কিন্তু দুটোর মধ্যে ডিফারেন্স। ওকে, সো সাপোজ if you are dividing the right lobe into anterior and posterior segment, what will happen? You are dividing anterior and posterior. Okay, and for the left lobe you are dividing medial and lateral. Medial konta towards the liver, okay, and lateral hocche away from the liver. Now what you are doing? You are just cutting in between. ঠিক আছে, টোটাল একটা কাট করলি, তাহলে কি কি কাট এলো? মানে আমি জিজ্ঞেস করছি চারটেটা কি করে আটটা হচ্ছে? এক্সপ্লেন মি দিস। এইভাবে যদি কাটিস তো ফার্স্ট রাইট ইট ডাউন, ফার্স্ট ক্লাসিফিকেশন উড বি কি হচ্ছে? অ্যান্টেরো সুপিরিয়র। ফার্স্ট ওয়ান ইজ অ্যান্টেরো সুপিরিয়র। ওকে, অ্যান্টেরো সুপিরিয়র, এটা কিন্তু রাইট লোবে হচ্ছে, ঠিক আছে, অ্যান্টেরো সুপিরিয়র। দেন নেক্সট ওয়ান ইজ অ্যান্টেরো ইনফিরিয়র। Okay, then posterior superior, then posterior inferior. Okay, so what about the medial lateral? বোঝা গেল? টোটালটাকে যদি তুই ভাগ করিস তাহলে অ্যান্টেরো সুপিরিয়র, অ্যান্টেরো ইনফিরিয়র, পোস্টেরিয়র সুপিরিয়র, পোস্টেরিয়র ইনফিরিয়র। হোয়াট অ্যাবাউট দ্য লেফট লোব? লেফট লোবটাকে আমি বলেছি মিডিয়াল আর ল্যাটারাল, তাহলে কি হবে? Superomedial, superomedial, inferomedial, then superolateral, inferolateral. So you are having 8 classification and you have to write along with the Italian letter. Okay, 1 to 8. So this is known as Cornier classification. Why this classification has been made? Do you know why it is made? for the purpose of surgical anatomy, okay, because you have to have the liver transplantation, okay. You know how many percent of a liver could regenerate by itself? Suppose if you are cutting particular person of liver, it could able to regenerate by itself. 30%. 30% যদি তুই রেখে দিস, it could regenerate by itself, okay. So this is the Connier's classification of liver, okay. Then we'll come across about the different vessels, okay. So write it down. Blood supply of liver. Blood supply of liver, already you know, it is supplied by 80% by portal vein and 20% by hepatic artery, and hepatic artery is coming from common hepatic artery, which is a branch of celiac trunk, What about the vein? Venous drainage. So venous drainage has got 3 veins, the right hepatic, left hepatic and intermediate. All are draining where? To the inferior vena cava, okay. This is one of the main tributary for inferior vena cava, okay. So write it down. Venous drainage, it has got right, left and intermediate hepatic vein, which finally drain on the inferior vena cava. Okay. So this is about the blood supply and venous drainage, okay. Now if you go little bit about the histology of liver, okay. So there are 2 type of liver cells. One is liver parenchymal cell and liver non-parenchymal cell. So if you go through the liver parenchyma, how many things it has got? What is the unit of liver cell? That is the hepatocytes. And how does it is looking? It is a hexagonal in shape, right? So which thing is found on the corner? At the middle you will get central vein, okay, and at the corner you are having the portal triad, okay. So we will go through this class of histology, okay, the brief structure about the liver, okay. So next you write about the gallbladder, little bit about the gallbladder. So where you will get the gallbladder? On the posterior inferior surface, and it is looking like a stomach, right? It is collecting the bile. So it has got the fundus body and the cystic duct, okay, and the cystic duct, okay. So what is happening? This hepatic duct is coming from the porta hepatis, and this cystic duct is coming from gallbladder. So both are making common bile duct. And where does it open? Which part of duodenum? Write it down. Both cystic duct and hepatic duct will form the common bile duct. And which finally open into the second part of duodenum. In ampulla of Vater. It is also known as major duodenal papilla. Okay. So this is about the gallbladder. So next we will come across what are the clinical anatomy you will get in the liver. Okay. So first one is inflammation of liver is known as hepatitis. Okay, inflammation of liver is known as hepatitis, and you know it is caused by the virus, hepatitis virus. There are how many types? Hepatitis A, B, C, D, E. Five types of virus. So mainly they are doing the hepatitis, inflammation of liver. Okay. Second disease you will get across on the liver, that is known as cirrhosis. Okay, cirrhosis. So what is cirrhosis? Before going to cirrhosis, there is deposition of fat on the liver. Okay. So tell me what are the function of liver? First one is the metabolism. Whatever glucose, whatever carbohydrate, protein, fat, right? So which process is occurring on the liver? देखिए हम biochemistry पढ़े gluconeogenesis. Okay, then glycogenolysis. Glycogen is breaking down, degraded into. Okay, then second process is the metabolism of amino acid, metabolism of fat. Okay, any other thing would be metabolized? Whatever we are eating. Okay, suppose if you are eating any medicine, if you are eating any water, or if you are eating anything which is poisonous, okay, any toxic substance, that is also going to the liver. Okay, whatever metabolism that is occurring on the liver. So first function is metabolism, second function is so secretion of bile. Okay, this is also known as mixed gland, right? It is one of the largest gland of our body. Okay, the second one is bile secretion. Third function is detoxification. Detoxification. Okay, detoxification is done by liver. Okay, আর কি কি synthesis করে বলতো? What about fibrinogen and clotting factor? Okay, so synthesis of fibrinogen and clotting factor. So these are all function of liver. Okay, so in case of fatty liver, plasma protein, very good, plasma protein. Okay, তোরা ভালো বলতে পারবি because you are now studying physiology. Okay, so we are having these things, synthesis of fibrinogen, synthesis of clotting factor and plasma protein. Okay, so these are the function of liver. And another one is storage of glycogen. Glycogen is stored on muscle and liver mainly. So these are the function of liver. Now what is, I am asking, hepatomegaly and fatty liver. Write it down, hepatomegaly and fatty liver. This is the most commonest finding nowadays. Okay, fatty liver. So what is occurring in the fatty liver? Excess fat has been deposited to the liver parenchyma. Okay, it is also known as ki bole etake steatosis. Steatosis. Okay, so if suppose fat has been accumulated on the liver, there would be liver size would be enlarged. So this is also known as hepatomegaly. Okay, so you write fat deposition of liver leads to fatty liver, steatosis and hepatomegaly. Okay, so if suppose gradual deposition of fat, so what is the function has been taken up by the liver, it won't occur. Okay, so gradually it will cause cirrhosis. Okay, gradually it leads to cirrhosis. There are so many toxic objects, basically the alcohol. Okay, so there are two types of steatosis. One is alcoholic, another one is non-alcoholic. Okay, these are the disease you will get. And then next one coming to the jaundice. Okay, so you all know jaundice is increased bilirubin. Okay, so how many type of jaundice you are having? Obstructive jaundice, another one is conjugated bilirubin, another one is unconjugated. কোনটা conjugated হবে? শোন সি আর ওটা একরকম, ঠিক আছে? সো ইট ইজ কনজুগেটেড হবে অবস্ট্রাকটিভ। ওকে, আর অবস্ট্রাকটিভ জন্ডিস কখন হবে? সাপোজ দেয়ার ইজ অ্যাকুমুলেশন অফ গলস্টোন। ওকে, suppose there is accumulation of gallstone in the common bile duct. Okay, what will happen? The bilirubin would be raised. So this is a cause, this is known as obstructive. Obstruction has been caused. Okay, so আর যেটা non obstructive হবে, that is unconjugated, that is caused due to unconjugated তো হতে পারে। So that is why it is coming due to any cause of hemolysis, তাই তো? তো hemolysis কি ভাবে হতে পারে? In case of malaria, kala-azar. So there you will see also hepatomegaly, also you will see this unconjugated type of jaundice. Okay, so these are the disease you will get. And if you talk about gallbladder, you will get two disease. একটাকে বলছে cholecystitis, another one is cholelithiasis. Okay, so what is cholelithiasis? Formation of gallstone. Okay, formation of gallstone. So how many type of stone would be formed? 2 type. Which are they? 2 type of stone has been formed. Okay, either it is coming from bile pigment. Okay, bile pigment তোরা জানিস কি কি pigment আছে? Sodium glycocolate, sodium taurocolate. So these are the stone. Okay, so that is the pigment stone, and the another one is cholesterol stone. Cholesterol stone, because what is the function of bile? Suppose anything coming to the stomach, acid chyme, it is mixed, it is churned. Now it is coming to the first part of duodenum. What will occur? Duto function hoy. There is secretion of which enzyme? Cholecystokinin, pancreozymin. It will cause contraction of gallbladder. So from there bile will come to this second part of duodenum. Okay. So that is the function of liver and the gallbladder. So when you will get this cholecystitis, suppose a stone has been formed on the gallbladder or on the common bile duct. What will happen? Inflammation of the gallbladder. Okay. The gallstone could be symptomatic as well as asymptomatic. দুটোই হতে পারে, ঠিক আছে? So this is the main function of liver and gallbladder. Okay. So now everything is cleared about the gross anatomy of liver. Now we will see on the viscera. Okay. I will explain. Okay. Thank you.